Hello all. Is somebody there that could help me or the second? Unmute thyself.
Hey, what's up, Haley?
Okay, great. So I'm going to show something and I want to see. So this, if I do this, do you see the presenter mode this way?
Yes.
Okay, we don't want that. But if I do this, you just see the slide, eh?
Yes.
Okay, thank you. That's all I needed. See, that was easy. So helpful.
Boom.
Huh. Is that Simon?
Yep.
Oh, can't give it away.
That's a pretty picture.
Isn't that nice?
Yeah.
Twin birds.
It makes me feel like it's cold, but also spring is coming, which is how I kind of feel.
Yeah, I know. Can you see my face?
No, it's all black.
Okay. Do you think that's okay? It says my video is going. Oh,
Here you are.
Oh, I look a little flustered.
Nah, you look great.
It's just really busy upstairs. Get comfortable here. Oh, people are gonna show their faces? Okay, I'll show my face. I'm very flustered. It's been a spicy morning upstairs.
You upstairs today?
No, that's the interesting part. There are 4 cerclages today.
Oh my goodness.
There's a lot of, there are 19 postpartum discharges though. 9.
Wow.
Postpartum list. I ran it only on like 13 yesterday.
19,
You
man.
can't all be going home.
I ran it on 12 the day before.
Yeah, thanks. Did some Nexplanons.
I just put an next one on right now for someone
Oh,
to help.
are you
Okay, so
doing
the
all
clinic-
4?
I don't know. Kelsey and I are gonna split it up. I don't know. Okay, there are 20 people here and I have 70 slides to get through. So I'm just gonna
Wait
start.
till 11:01. 11:01.
Okay, 11:01. 70 slides. We might get through them all. We might not. Who knows? I'm going to mute all your faces because it's very distracting
I
for
bet
me.
you'll get through all the slides. You're a fast talker.
I am a fast talker, but you know me, I'm a little manic too. So if I need to slow down, just speak up. 11:01. 23. I'm gonna start. We good?
You're good. Go for it.
We're good. Let's go. PDC Conference, February 11th, 2022. Twins. Look, there are 2 little birds there. They're twins. It's going to be a little bit different today. So I just want to outline some objectives of what I want to talk about. We'll talk about background information on twin pregnancies. We'll review diagnosis of twin pregnancies, outline some complications, talk about 2 cases that we've recently had at UW, and then review some complications unique to monochorionic twin pregnancies, TTTS, TAP, selective fetal growth restriction, TRAP, and a single twin demise. A lot to get through. I'm a big fan of People Magazine. This is your first pop quiz of today. These are identical twins who married each other. How related are their children? They're cousin siblings. Fun fact number 1. Here we go. Twin gestations. So the natural incidence of twin gestations are not that common. Monozygotic twin rate is 4 in 1,000. Dizygotic is a little bit higher. And then rates will vary based on other individual characteristics. So one's race, Asians have less likely to have twins as opposed to people of African descent have higher likelihood. Age, the older you are, AMA, more likely to have twins, parity, advanced parity. Maternal family history is also a factor for monozygotic twins. The actual incidence, though, is heavily influenced by the use of art since the 1980s. The twin birth rate has increased 76% from 1980 to 2009, and it recently peaked in 2013 with a birth rate of 33.7 per 1,000 births, as you can see on the graph over to your right. Again, most of these twins are going to be dizygotic
No, because it's already
by art.
because I was sending her a saliva. It's okay. Yeah.
Can everyone else mute themselves?
Mute, Sheila. Thank you. Most are dizygotic, again, influenced by art, but the monozygotic twin rate is also influenced by art up to 3 to 5%. And then more than 50% of multiple gestations in developed countries nowadays are from art pregnancies. So types of twins, just to review these briefly, you have monozygotic and dizygotic twins. Dr. Ma taught me this when I was a little resident. The majority are going to be dizygotic twins. That means 2 separate eggs fertilized by 2 different separate sperm, making 2 different babies. They're essentially siblings that are just sharing a womb. And then there are monozygotic twins, which are less likely, about 20 to 33% of twins. And that is the schema to the right with those 3 blue columns. So with monozygotic twins, you can have a couple of different situations. You can still have dichorionic, diamniotic twins. That's if that postzygotic split happens very early, day 1 to 3. Then the next, if that split happens a little later, you get monochorionic diamniotic twins. Between day 8 and 13, you get momos, and then conjoined twins. Dr. Ma likes to say unlucky number 13 if they split after day 13. So that's a little schema of that. Diagnosis is very, very important because it guides your management and counseling for these patients. So here are some first trimester ultrasound features. First, new patient comes in, you want to count the number of sacs and the number of fetuses to figure out the chorionicity. So that's first. So if each sac has 1 fetus and you see a thick chorionic lining, you have dichorionic diamniotic twins. That's over here. So number of amnions, number of chorions are equal. Over on the right, if you have 1 sac with 2 fetuses, it's a monochorionic pregnancy. But you still have to wait because you might not see the membrane or lack of membrane to determine if they're momos or modi twins. So you have to wait until at least 8 weeks. The ideal time's around 10 weeks via transvaginal ultrasound to see if you can see the amnion. Another way in the first trimester, a quick tip is if you see 2 fetuses and 2 yolk sacs, it's most likely a modi twin pregnancy. And you see 2 fetuses with 1 yolk sac, that's probably momos. Fun fact. And so then later, on that 10-week ultrasound, 1 amnio, 2 fetuses, amnion with 2 fetuses, momos, 1 amnion per embryo, each has their own sac, modi. So second trimester ultrasound features. Let's start with the dyes. You would see potentially 2 placentas, 1 anterior, 1 posterior. That's a di twin pregnancy, but a lot of times these can be fused. So you just see 1 big placental mass. It's hard to tell. Fetal sex, they can be different. If you see a boy and a girl, you know you have dyes, the same, unclear. And then the dividing membrane characteristics are really huge here. So this twin peak sign, which I'll show in a second, is characteristic of di twins. And then thick membranes in between the 2 sacs is another characteristic, or if you can actually count 3 to 4 layers of those amnion and chorion separation. In terms of monochorionic twins, you have the modis, you'd see 1 placenta, right? With both monochorionic twins, 1 placenta. The fetal sex would be the same. Genetic counselors, yes, there can be fetal sex dichimerism. It's incredibly, incredibly rare. And then with the monochorionic diamniotic twins, you won't see that twin peak sign, but you will see a membrane, a thin membrane with the T sign, which I'll show in a second. And the momos, they have no membrane in between the 2. They are sharing 1 hot tub. So here we go. Up top, dichorionic twins. Here's your twin peak sign or your lambda sign. I like to think that there's like all this extra chorion. I call it like chorionic cleavage, just like filling the space. And that's how you get that lambda sign. And then this is what it looks like on ultrasound. Beautiful, beautiful. Monochorionic diamniotic twins. We have our T sign, right? Same thing. The membrane just comes perfectly down. There's no chorionic cleavage. And then you see that here on the ultrasound. Great. So here's what this looks like. Here's your dichorionic, diamniotic. You see 2 sacs with nice thick chorionic ring around. And then this is just histologic because I got really into it. 2 chorionic layers, 2 amniotic layers, 2 chorionic layers, and then trophoblastic tissue in between. Here's the monochorionic diamniotic twins. Again, 2 yolk sacs, 2 fetuses, and 1 gestational sac. And then later, if you were to wait a little bit later, you'd be able to see that membrane. You get that nice T sign. And again, here we just have the 2 amnion layers with really thin basement membrane in between. Looks like bacon. And then here's the monochorionic monoamniotic twins. This picture on the left makes me like really nervous because they look like they're already cord entangling, but that's the point. You have 2 fetuses and 1 hot tub, no membrane in between, 1 placenta. Pop quiz. Here we go. Are you paying attention? Your patient comes in, you pop on the ultrasound, and what do you see? Oh, I see one sac with a membrane, and that looks like a lambda sign. Oh, what is it? Okay.
Tie-dyes.
Twins.
I think it's tie-dye twins. Excellent. But then you like start spelunking around a little bit more, and you see this posterior sac has
Triplets.
bingo, bango. Dr. Ma, these are my favorite triplets from residency. So these, this was a spontaneous dichorionic triamniotic triplet pregnancy. The boys on the outside are identical twins. They're in here, and the girl was here. Fun fact. Okay, a word on multiples before we move on. Dr. Alyssa Stevenson Famey told me this quote that Dr. Easterling used to say, that twins can hurt you in so many ways. He's so wonderful. So let's talk about some complications of twin pregnancies. The loss rate, first trimester, second trimester, third trimester is significantly increased. Aneuploidy rates are increased. Anomalies increased. Growth restriction is huge. The preterm birth rate listed here is significantly high. The median gestational age for twins, I think, is 35 weeks. Triplets, it's 31.7 weeks, and quads, it's about 28 to 30 weeks. So that's a huge comorbidity and all the complications that go with that. And then maternal complications listed here: hypertensive diseases, HELP, acute fatty liver pregnancy, hyperemesis, PUPS, GDM, cholestasis, abruption, postpartum hemorrhage, all the stuff. More placental mass, more problems. And then there are specific complications related to monochorionic pregnancies, which we'll talk about later. And that's because two people are sharing one placenta. So here we have a picture of a velamentous cord insertion, which is really the root of most problems. And then you have two babies affected by TTTS. So just to review, this is like a proposed ultrasound protocol for monochorionic diamniotic twins, knowing that the prognosis of twins is dependent on chorionicity, not zygosity, and the perinatal morbidity and mortality of MODI twins or monochorionic twins is 3 to 5 times that of di twins. So these ultrasound protocols are really important. So we would identify twins and maintain their identity through pregnancy. It's really important to identify the cord insertion, any discordant growth, and any unique anomalies. We do an NT scan at 10 to 13 weeks because there's a lot of things that we can't identify then, and it's good for aneuploidy screening. TTTS surveillance starts every 2 weeks, starting at 36 weeks, and really to the end of pregnancy, at least to 28 weeks. We're looking at basically at minimum bladders and the max vertical pocket of amniotic fluid for each. Serial growth scans up really most of the algorithms or the protocols I found say 4 weeks, but you can do it as early as 2. And then a lot of people will say, like ACOG, consider the use of Doppler, umbilical artery Dopplers, ductus venosus Dopplers, umbilical vein Dopplers, and MCA Dopplers. And then we're looking for complications of monochorionic twinning, unequal placental sharing, TTTS, TAPS, and TRAP. And then we're performing fetal echo at 18 to 22 weeks because with monochorionic twins, they have a 5-fold increased risk for congenital heart disease compared to others. All right, woo, case 1, we feeling good? Let's get going. So we have a 30-year-old G2P1 001 at 16 and 4 who presents in consultation in UW with a spontaneous MODI twin pregnancy. Her past medical history, she has some psychosocial issues, but nothing major from a medical standpoint. Meds, she's on prenatal vitamin and aspirin, and she has a history of a 38-week uncomplicated vaginal delivery. So her ultrasound findings here, twin A is in this 26th percentile, has polyhydramnios with an MVP of 8. And the anatomy looks good and we see a bladder. Twin B, EFW is less than 1%. The baby appears stuck against the wall of the uterus. Oligohydramnios with an MVP of 1.2. Anatomy looks good, can't see a bladder. UA Dopplers are normal, MCA Dopplers are normal, and ductus venosus Dopplers are abnormal, showing absent and reversed A-wave flow. So these are just some pictures I clipped from her images. On the left here, this is baby A, and I just want you to notice that if you were to look at all these scans, baby B is just chilling up here the entire ultrasound and not really moving. That's that stuck appearance. We have a nice big max vertical pocket, consistent with poly for A, and then look at that beautiful bladder. Again, look, baby B's just chilling up here. And then for baby B, again, just totally stuck against the side wall. This is actually the membrane here. And then this is the max vertical pocket for B. So like super tiny. And you can see here, I just threw the ductus. There wasn't a bladder, promise. The ductus venosus waves, and you can see there's this A wave should be above, and we see this A wave consistently reversed below here. So the next day, she gets referred to Seattle Children's. Repeat ultrasound again, confirmed stage 3 TTTS. I have put the staging here. We'll talk about it a little bit later, but just to guide you in looking at this. So in A, they see normal EFW, poly, and a bladder is seen again. They say normal Dopplers. They say reversed A-wave flow for the recipient, and the Tay indices, which is a measurement of cardiac function, are abnormal with evidence of thickened myocardium, so like evidence of brewing cardiomegaly and dysfunction. B is the donor. Anatomy is normal, but less than first percentile. Oligohydramnios, the umbilical Dopplers here show absent flow. MCA and ductus venosus are normal, and then this baby has normal Tay indices. So this patient is recommended to have a laser procedure, which she does the next day. So this was like a Wednesday, Thursday, Friday stitch or something like that, Tuesday, Wednesday, Thursday. And so this is essentially what laser looks like. You see your poly baby, and then this is your recipient, this is your donor, and they go in with this scope, and they're gonna laser these anastomoses. So regional anesthesia, they just place a spinal or an epidural, I think just a spinal. They go under with intraoperative ultrasound guidance. They place this 3mm catheter into the recipient sac where all the fluid is, and they fill it up more with some amnio infusion. Then they place like a 1mm stethoscope, and they find the reflection of the membranes between the two fetuses, this guy here. And then they identify all of these vessels crossing this reflection and the anastomoses, and they ablate them with this laser. For this patient, there were 5 anastomoses, and this can vary. And then they solemnized the placenta to dichorionize it. And then they did an amnio reduction at the end of all that fluid. So they took out the 300 they put in and a little extra. So this is that scope under ultrasound guidance going in. And then these are sort of pictures of what that laser looks like. But wait, I have an actual video. So this is what laser looks like. So here they're under ultrasound guidance. There they are going with the scope. And we're not going to watch the whole thing, but this first part's pretty profound. So here's the baby. There's the stuck twin on the left. Check that out. It's like saran wrapped. You can see the face, the eyes, the chin, and the hands are just like up by the face, totally stuck. You can see the cord completely stuck down. And then here's the other baby in that huge poly sac, just chilling. All that room. Her heart isn't happy, but all this fluid. So this is kind of what they look like. And then I was gonna pop ahead a little bit. So there's an internal, this is not this patient, this is just an example, but there's the cervix with the big vessel going right over it. That's kind of cool. And then there's the reflection and all the vessels sort of going up to it. So they're just, they map out the reflection. You can see the fetoscope there, and then they pull out their laser, and then they're gonna start buzzing all these, I'll get one buzz here. And they laser. There we go. And so that's what that looks like. And they just kind of go along and find each one and buzz, buzz, buzz. And so, yeah, so after they ablate, they coagulate those anastomoses, then they move on to what's called Solomonizing the placenta, which is kind of interesting too. Think of there's the biblical story of King Solomon and the two moms that had the baby, and they were both arguing, and then he said, well, let's just cut it down the middle, and then the real mom stepped up. It's like, no, that's my baby. That's where that comes from. Essentially, the initial fetal laser ablative techniques were non-selective in nature, and they just buzzed every blood vessel that they could find. And then they've sort of evolved to have selective and selective sequential techniques where they were only lasering the pathologic intertwin anastomoses. And then the selective sequential is when they get rid of the donor to recipient ones first to kind of maybe help boost the hemodynamic stability of the donor, and then get from the other side of the connections second. And then the Solomon technique is essentially what Dr. Peck and Dr. Martin call these little breadcrumbs. So they sort of get the vessels and then they drop other little laser spots, and then they essentially just connect all of the line. And there's a 2015 systematic review that compared selective versus the Solomon technique and found a trend towards a reduction in recurrent TTS and TAPS development after laser treatment, with an increase in twin survival without complications. So you can see this placenta here. This is this line of solemnization from previous. So one cord's over here, the other one's over here, and this is where the laser occurred. It's kind of cool. Here's her post-op day 1 ultrasound. Again, viable monochorionic diamniotic twins, good heartbeats, euhydramnios of twin A. So the poly has resolved in the one, and the fluid is normalizing in twin B. You can see we actually have we're getting a little bit better there. And then the Dopplers were improving early on, but there's that little pocket. And then this is sort of all the data from her subsequent ultrasounds. So again, baby A is the recipient, baby B was the donor. And you can sort of see the growth for A sort of fell off here towards the end, but the polyhydramnios improved significantly. The Dopplers danced around. There was no evidence of TAPS. And then for baby B stayed small the entire time. The bladder was not seen, and then we could see it with normal fluid, which is great. The Dopplers progressively got worse with this growth restriction. No TAPS. We flirted with TAPS a little bit, but no TAPS. And then the discordance was pretty consistent. Her clinical course, she got admitted, I think, here on like the 13th for non-reassuring tracing in clinic. She was diagnosed with gestational hypertension 2 days later. And then at 31 and 4, her repeat Doppler ultrasound showed that twin A had elevated for twin A and intermittent reversed flow for twin B on Doppler. And then their monitoring was showing progression of fetal heart rate decelerations. And so it was time to have babies. 31 and 4, pretty good. So baby A, the former recipient, weighed 2 pounds, 12 ounces, good gases, good Apgars. And then baby B, who was supposed to be the really tiny baby, was a little bit bigger.
They were reversed. Like B ended up.
That makes a lot more sense.
Yeah, sorry.
Like, how did that tiny little baby grow?
So yeah.
Okay, so this is actually B. Oh, I wish I would have known that. Okay, that's fine. Thank you for clarifying. And then both babies remain in the NICU. They're still on CPAP, but they're gaining weight and doing well. This is her placenta. So the path department sent me this guy, and here is where the scarring from the laser and the solemnization occurred. Unfortunately, you can't see the other cord, but I'm assuming it's probably somewhere over here, because usually that plane is equidistant and kind of right in between the two. So there's probably like a cord over here, and then this is like the membrane.
Haley,
Yo.
go back.
Yeah.
So another important, they're both marginal cord insertion, right?
One was.
Just
Well,
one.
yeah, I guess that looks marginal. I think this one might be velamentous.
That's a velamentous or marginal. So that's always a early warning sign. If you see that earlier, that high risk for TTP.
Don't worry, I'm getting there for sure. So monochorionic placental physiology, just to touch on this later a little bit. You have one placenta with this nice 2-layer intertwin membrane attached to this single chorionic plate. So this is the fetal side. They will all have vascular anastomosis crossing this intertwin membrane, characterized based on their anatomic relationships. So arteries always run over veins. And so the artery to artery and the artery to vein are all superficial with bidirectional flow. The artery to vein anastomoses, they're all on the surface, but actually where they connect to each other are deep in the placenta within, cotyledon, I never said that word right. So deep in the placenta, the actual connections, but they cross superficially. And they are obligatorily unidirectional, artery to vein, okay? And so they all have AA, VV, and AV, but they should all have the same or kind of a balanced proportion going back and forth, and you don't get TTTS. It's when it's unbalanced and there's a predominant A to V unbalanced flow where you get into problems. So twin to twin, that's what it is. Transfusion syndrome caused by intrauterine transfusion of blood from one donor twin to the recipient through these unbalanced AV placental anastomoses. It affects about 10 to 20% of monochorionic amniotic twins. It can affect momos, but it's quite rare. It counts for up to 50% of all perinatal deaths in these twins. And the loss rate is quite high for advanced stages, so 3 and 4 and 5. Most often it's diagnosed in the second trimester, but it does not always progress in a predictable manner. And sometimes you can have intrapartum TTTS that just happens at the time of labor. Like late in the game. The Quintero staging comes from a 1999 paper by Quintero et al. It's the classification system of choice, but there's a lot of critique of the system. It doesn't represent chronological order of twin deterioration, number one, and the stages do not correlate perfectly with perinatal survival, but this is still what we use to guide our therapeutic interventions. A little on the pathophysiology of TTTS. Again, the primary event is a flow imbalance from donor to recipient across these anastomoses. You get this uncompensated flow that results in hypovolemic anemic donor and then a hypervolemic polycythemic recipient. Then you have what further sort of clouds the picture, makes it worse, is you get these vasoactive substances and volume overload that play in. So the volume changes induce modulation of hormonal and biochemical regulators in the twins, and you get this exaggerated hemodynamic response. The RAS system gets upregulated in the donor twin and downregulated in the recipient initially. But remember, all of their blood supply is connected through these anastomoses. So they share the circulation, and then ultimately they both have renin, a RAS increase. And so that's really not what you want in the recipient. And that like further drives this hemodynamic response. And then you get all these other vasoactive substances, ANP, BNP, endothelin 1 are higher in the recipient. And a lot of that is what leads to the cardiac dysfunction in these babies. Another note on the anastomoses, so the arterial to arterial anastomoses, again, are bidirectional, and they can often compensate for flow imbalance. And it's found that it's believed that more AA anastomoses in twins is protective against developing TTTS. Ultrasound findings, starting with first trimester findings, a crown rump length discordance has been noted in the literature, and then a discrepancy in the nuchal translucency, a discordance there. But these, I think with further studies, have shown to not be as reliable. That now the newest literature is saying that this reversal or absence of the ductus venosus A wave on first trimester ultrasound has been the most promising. Second trimester kind of listed over here, oligohydramnios, stuck twin, and abnormal Dopplers for the donor twin. And then recipient twin, you have polyhydramnios. The Doppler abnormalities here, you'll see with the ductus venosus and the umbilical vein, which are showing overload, that heart is being overworked by all that volume. So for the ductus venosus, you're looking for that reversed A wave flow, like I showed earlier, or pulsatility in the ductus venosus, which is not normal. And that just means that the heart is handling a lot. Or you're looking for a pulsatile umbilical vein flow, which is also not normal. And those are both signs of that indicates imminent high drops. It's no bueno. Umbilical artery abnormalities are less common recipients, but they can happen with both. And then with the recipient baby, remember handling all that extra fluid, cardiomyopathy can result due to the volume overload. So you'd see signs of cardiomegaly, tricuspid regurgitation, impaired ventricular biventricular function. And as a result, left heart, right heart fails, then you get RVOT obstruction, and it essentially leads to like pulmonic stenosis in these kids, and right heart failure. And then here, just for you, Dr. Wang, looking for the cord insertion is very important because over 50% of cases will have one. Here are these pictures up on the left. Here's your poly. Here's your stuck twin with your ollie. No bladder seen here. Nice bladder seen here. This is some cardiomegaly of a recipient twin. These are these membranes that get folded over. This is the donor twin. And just think of like it's in a sack and then you drain all the fluid out of it and the membranes sort of like collapse onto themselves and they make these like spikes that come off the baby. So it's kind of interesting. And then down over here, sometimes you can see this with TTTS and with TAPS where you have this tonality of the placenta. So in the recipient placenta, it's more hydropic and there's more fluid and it's brighter. And then in the donor, it's like more shrunken down and looks darker. And then over here, here's your ductus venosus. So this is normal. You have this A wave. This is a normal Doppler. And then this is reversed A wave flow through your ductus venosus. Just touch on cardiac disease briefly, because I overdid it on this lecture. 9-fold increase of cardiac anomalies in Modi twins, 14-fold increase in those affected with TTTS. Usually ranges from most likely septal defects, but again, that RVOT obstruction can come in the setting of TTTS in the recipient twin, which leads to pulmonic stenosis and stuff. The functional cardiac anomalies, I think I just said that, so I won't say it again, but there you go. There's that pulmonic stenosis. So then they use TAE indices, which are myocardial performance index of the global ventricular performance using Dopplers, and that's what those pictures are over here on the right. I'm not going to get into the math on this, but essentially they're looking at systolic and diastolic function. Donors should have normal TAE indices, and the recipients are the ones that are going to be abnormal. So 70% will show evidence of diastolic dysfunction, and that overall increases their risk for IUFD. They can develop ventricular hypertrophy, AV valve regurgitation, abnormal RV function, and LV function. And so some will actually use this fetal echo as part of their TTTS surveillance. There have been some scoring systems that include cardiac dysfunction that are out there, but they're not very useful in predicting outcomes. And so they're still quite controversial. But interestingly, cardiac dysfunction can also be detected in up to 10% of early stage TTTS, like stage 1. And so that's why a lot of people use them to help identify those in need of early intervention. That's the rationale for that. So treatments, just to run through these quickly, expectant management is one option, do nothing and watch. There more than 75% of stage 1 TTTS cases will remain stable or regress and don't do anything. Amnio, so stage 2 then through 5 or 4, these are other options. So amnio reduction, where you remove fluid from the recipient sac. It's thought to potentially reduce the intraamniotic placental intravascular pressures, and then facilitating placental blood flow, usually the venous connections, and then possibly reduce the incidence of preterm labor from polyhydramnios. People do this at different frequencies. So it's usually when the MVP is greater than 8, and the goal is to decrease it to 5 to 6. Some people do it one time, and then other people do it serially. The thing to remember is that there can be more complications the more times you're doing amnio reduction, infection, PPROM, chorion amnion separation, whatnot, that then if people need lasers, it makes it very difficult to do. This option of an intentional septostomy of the intervening membrane is really a thing of the past. They don't do it anymore, really, where you poke holes in the membrane in between the two is a thought to sort of equalize the fluid across the sacs. It's not effective in the literature, and it can lead to a mo situation because you can tear through that membrane and then you have one hot tub with 2 babies with no membrane in between. Fetoscopic laser photocoagulation of these placental anastomoses is newer, probably the newest technique of all of these. The goal is to functionally separate the placenta, that dicoronization, and then selective reduction, which is interrupting the umbilical cord flow to cause the death of one twin, the one that's struggling, to improve outcomes for the surviving twin. They use radio frequency ablation for this, or cord coagulation, and it's reserved for advanced stages, so stage 3 and 4. So here's a management algorithm, essentially. You have a diagnosis of TTS, and then the plan is to start doing staging. Stage 1, sort of counseling, plan for expectant management. Maybe you increase the frequency to weekly ultrasound checks. And then stage 2 through 4, you're really going to counsel that they need to be referred to Seattle Children's now that we have our fetal therapy center for laser. Stage 5 is when one twin demises. And in that situation, it's really just to provide counseling that there's an increased risk of demise of the other baby, and also significant risk of neurologic complications, but it is not an indication to deliver. So we'll talk about that in a second. So briefly, outcomes after laser, survival is 50 to 70%. Fetal demise rates 10 to 30%. So the donor, a growth restricted donor with abnormal UA Doppler indices has a 20 to 40% increased risk of demise. And then the recipient demise is actually more common with fetal growth restriction, reversed A wave in the ductus or hydrops. The MVP should normalize in 14 days. And the risk of PPROM with this procedure is about 10, I've seen up to 30%, but 10%. Cardiac dysfunction will actually normalize in the recipient twin in about a month, 4 weeks. And there's some studies that show that the majority of those who survive will have normal echoes at 2 years of life. And then neurologic complications with TTTS, that picture is a little bit cloudier, and the etiology is multifactorial, as a lot of these babies can be growth restricted and are born pretty prematurely. And so there are complications with that are muddy the water a little bit. But the rates have been quoted anywhere between 5 to 20% in survivors, but that's all stages of TTTS. And there's some conflicting data regarding improvement in neurological outcomes after laser in the studies that are out there. So some show that initially neurological outcomes are better, but then later there's no difference and stuff like that. So that's TTTS. Any questions? How are we doing on time? Okay. I'm gonna keep talking. I hope you're all still there. Case 2, 37-year-old G1 at 27 and 3 with a spontaneous monochorionic diamniotic twin pregnancy, referred today comes to UW from Idaho with a new diagnosis of hydrops and elevated MCA Dopplers and ascites. So they're worried about hydrops. So there's MCA Dopplers are elevated and ascites for twin B. She is very healthy. It's been a pretty uncomplicated pregnancy. So her outside ultrasounds, she's dated by her period and a 9-week ultrasound. She comes in initially, they think that she has the dichorionic triamniotic pregnancy. There's this extra sac-like structure that they think was like its own pregnancy. Kind of cool. That then went away. She has an anterior placenta, normal NTs, normal anatomy, normal echo. TTTS screening has been totally normal, and then boom, right at 27 weeks, twin A has the ductus venosus has mildly increased resistance with a positive A wave. Still okay. The liver appears echogenic with a starry sky appearance. They specifically use those words. And then twin B has new ascites, elevated MCA Dopplers, and then the ductus venosus shows increased resistance with the positive A wave. And these is what this looks like. So she comes to UW on the 13th right here after having that. So this is her ultrasound here. A, well grown on the 49th percentile. The discordance among these babies is 2%. MVP is still good, bladder's there. And the MCA Dopplers are 0.78 MOMs. So that is not normal. And then this baby also well grown, bladder's normal, good fluid, maybe a little hydrocele, but otherwise normal anatomy. They see this, we see a 5 millimeter echogenic focus in the left upper quadrant. We do see mild ascites, and we also see abnormal MCA Dopplers. Those are too high. So too low and too high. So these are some images. These are their MCA Dopplers listed here. So baby A, that's a little low. And baby B, that's pretty high. And then these are baby B, and I was just trying to show this is that little focus. So you can see some ascites, you can see some ascites around here, and then you see this like bright spot in the liver. Otherwise, I don't know, not very starry skyish, but anyways. So here's her clinical course. She sees the NICU, she gets steroids. We repeat an ultrasound that show a little bit later that shows she's got worsening ascites. And so she's counseled on the concern for developing TAPS, spontaneous TAPS, and we recommend an intrauterine fetal blood transfusion. This is performed at 27 and 4. So her opening, the baby's opening crit is 19. We transfuse 24 cc's of red blood cells to twin B. And when we were doing that, twin B was noted to have bradycardia down to the 80s and 90s, and the heart appeared just like really globular and dilated and was not contracting very well. And so we stopped the procedure. Unfortunately, we couldn't get a crit at the end of that due to significant vasospasm in the vessel. And that's her Doppler, MCA Doppler after the procedure, which is hard to make of that because she hasn't equilibrated yet. The fetal heart rate improves over the next couple of minutes, kind of up to hundreds, and then normalizes, and we all go, whew, and walk on. So then we repeat Dopplers, which are improved, and the ascites is pretty much significantly improved the next day. We talk about a potential of doing another IUT with smaller volume transfusion under regional anesthesia in case C-section is indicated for fetal distress, thinking that potentially the donor in this situation that is anemic is this concern for this high cardiac output failure. The heart is just like not able to tolerate large transfusions. So we're going to do little transfusions in the OR, epidural in place, just in case she needs to be sectioned. So the opening crit here is 26 this time. It's a couple of days later. We only get in 14 cc's. We just kept it small. And there were no bradycardia or vasospasm. And she stays pregnant. So then we get another, I think, scan the following day. We're planning on potentially doing another, go back here. So she stays stable, and then a couple days later again, for twin B, the MCA Dopplers are elevated and decreased for twin A. And so we talk about doing a third IUT because ultrasound now also reveals that the ascites has come back. And we kind of talked to the patient about it and counseled, like, where are we going with this? Just seeing as how this baby's not tolerating these transfusions well, how many more are we going to do? Risks and benefits, risks to the other baby who is now seeing all this transfusion, right? That recipient twin. And so we make the decision after counseling the patient to proceed with delivery. And so she ends up having a C-section delivery at 28 and 3. So these are the delivery details. I think I have these babies right, but the recipient baby appears plethoric with a crit of 71, and the donor baby appears pale with a crit of 21, and the Apgars aren't super great. The gases are good. So twin B, this is kind of what happened in the NICU. Twin B, who's the donor, got 2 blood transfusions and then some iron. And ultimately had a crit of 33 a day of discharge. They just discharged in January at 39 weeks. And then brother went home a couple days later and just received 1 partial exchange transfusion for the elevated crit, and then got some phototherapy with an improved bilirubin down to normal range prior to discharge. And then they drove home into the sunset, into the Idaho sunset. So this is a example of TAPS. So TAPS, essentially what it is, twin anemia polycythemia sequence, is a chronic form of TTTS caused by a slow transfusion of red blood cells through a very small, less than 1 millimeter diameter placental AV anastomoses in the monochorionic twins. So it's like TTTS, but really, really, really tiny vessels that are like only able to let red blood cells one at a time go by. Most often this is going to occur after laser therapy for TTTS. So that's in 2 to 16% of cases. And it just results from residual anastomoses that weren't coagulated at the time of the laser. It can occur spontaneously, as happened with this patient in 3 to 5% of cases. It can develop anywhere, really. It's like as early as 15 weeks, second and third trimester, and previously uncomplicated pregnancies, which is what happened here. And it can coexist with TTTS, which makes it a little bit trickier. Isolated TAPS is much rarer. And so these pictures are just showing TAPS. This is sort of the volume compared to TTTS on an earlier slide. These are the MCA Dopplers that are discrepant. And then you have two, this is just showing the anastomoses, the AV anastomoses, very tiny. Briefly, just talking about TAPS placentas, they look different. So spontaneous TAPS, there's a greater distance between the placental cord insertions, and there are fewer superficial anastomoses. They do not have a lot of arterial to arterial connections, and their AV anastomoses are deep in the placenta. And very, very small. And then post-TAPS, it's usually a single unidirectional AV anastomoses. There's no compensating flow from the AA and the VV anastomoses because they essentially took them away. And then what's interesting, in about half of these cases, the role reversal happens in post-laser TAPS. So the former TTTS recipient becomes the anemic TAPS donor and vice versa. So that's kind of cool. So this is a normal placenta up here, and then this is just a post-laser and then a spontaneous TAPS. Placentas are so cool to me. Diagnostic criteria for TAPS is a little controversial, but essentially you're getting MCA. All you really need is MCA Dopplers. So you're measuring the PSV at the axial plane within 2 millimeters of the takeoff from the circle of Willis. The diagnostic, there's traditional diagnostic criteria, which was the MCV, PSV. So this would be the donor with greater than 1.5 multiples of the median. And then in the recipient less than 1.0, but then there's this Delphi consensus, which also plays into when we talk about selective growth restriction in 2018, and they sort of changed the definition for this. So not only did they change the absolute diagnostic criteria, they also use a delta MCA PSV, interestingly, that they felt is more stronger of a predictor. But these cases detected have based on this criteria have led to an increased rate of intervention in TAPS affected fetuses. So that's kind of interesting. So that's just showing you the staging. Essentially, you can stage this prenatally based on this ultrasound criteria, which are listed here. So this is the conventional criteria. And I think we left this out here in stage 2. This is supposed to be 1.7. I think they forgot to put that in there. But this is the conventional traditional, and then this is the modified from that Delphi consensus using the delta MCA Dopplers among the twins. And then this is the original postnatal criteria was just hemoglobin difference. So prenatally, you can screen with ultrasound. Postnatally, it used to be hemoglobin difference, but now they've updated it and they've added a reticulocyte count on day of life 1. And if the reticulocyte ratio is greater than 1.7, that also supports a TAPS diagnosis, because remember, the reticulocyte count is rising in more of a chronic situation. So if you get like acute intrapartum TTTS or TAPS, where you get this huge placental fetal transfusion, maybe the first twin delivers and the other baby gets a big transfusion, there's a discrepancy or discordance, or you get acute intrapartum TTTS, those would both have like normal reticulocyte counts because the bone marrow hasn't gotten a chance to respond, versus a chronic picture of TAPS, you're gonna have an elevated reticulocyte count on the donor. And then postnatal diagnosis, just a little bit more, this is this updated criteria. And so this is really important because this will actually guide to understand if it's actual TAPS versus an intrapartum TTTS or something. The way that they treat these babies is very differently. They have to be much more mild and careful and conservative in how they exchange, transfuse, or these babies, because they're hemodynamic, they're a little bit more tenuous from a hemodynamic standpoint, as we saw when we gave that IUT to that one kid, and it did not like it very much. And so the additional criteria I talked about already, the reticulocyte count. And then the other piece that they've added is placental pathology. So this is a picture of a classic TAPS placenta, where you have clearly a really dark one side this is like the recipient side, and this would be the donor side. This is the maternal surface of the placenta, as opposed to all this TTTS business and all these anastomosis. We're looking on the fetal surface. So that's that. So our patient, just because I got real curious and I was like, what are these babies? What do these look like? So twin B, who's the donor, day of life 1, hemoglobin was 6.3. Unfortunately, we didn't have a reticulocyte count for day of life 1, but there was an elevated one from day of life 12. And then the recipient, baby A, the hemoglobin was 24. Yeah. So that is a big difference. And that would land them in stage 3. But you have to also remember, I think it's stage 3. Oh, no, it's stage 4. So I think ultrasound, they were diagnosed stage 3 prenatally, and then on postnatal, it's stage 4. But this is also with those 2 intrauterine transfusions. So I was unable to get a placental picture for this case, but I pulled up the placental path and there was no mention of there being like a 2-toned placenta going on. So just throw that out there. Here's some ultrasound features of TAPS. You have your MCA Dopplers that are discordant at the top. There's this placental dichotomy where you see the different echogenicity between the 2 placental chairs. The donor placenta is going to be hydropic and thicker with increased echogenicity, which is like this guy here. And then the recipient will look normal or flattened even. Cardiomegaly due to high output state and fetal growth restriction is very common in donors, up to 70%. This starry sky appearance in the liver is in 66% of recipients, and that is in the setting of hepatocyte edema that makes those portal triads stand out, and that's what you're seeing as being those little bright starry spots in the sky, and that's what this is here and this is here. They usually have no amniotic fluid discordance, but TAPS can coexist with TTTS in about 15% of cases. And an increasing number of signs, like all these things put together, correlates really with higher stage of disease. Treatment options, pretty much the same. Expectant management totally can resolve in like 16% of cases. This will completely go away. Preterm delivery, intrauterine blood transfusion with or without partial exchange transfusion in the recipient twin. Then there's laser and selective feticide in really bad cases. And so I was able to find a 2021 meta-analysis and systematic review found that the rates of perinatal morbidity and mortality are much higher in post-laser TAPS versus spontaneous TAPS. But this study was a little flawed. So there's the best treatment option is still unclear at this point, and it's currently being investigated in this international multi-center randomized controlled trial called the TAPS trial, which is supposed to be coming to a theater near you in 2022. Are we there yet? Is it 2022? I think it is. So TAPS outcomes, perinatal mortality, IUFD rate is 9% in spontaneous TAPS, which again, it's higher, 18% in the post-laser TAPS. Donors have a 4-fold increased risk of mortality. Remember, that's that donor, that's that anemic, high cardiac output baby. Neonatal morbidity and mortality is actually, it's about 30 to 40% of TAPS twins. The morbidity with really no difference between donors and recipients. So it's really that antenatal risk. These babies are wrought with hematologic complications and significant risk for cerebral injury in both the anemic and the polycythemic babies. The donors have low albumin protein. They end up having a leukopenia, anemia, and thrombocytopenia, as well as AKI, which is really interesting that like, why are there, oh yeah, no. I have that wrong. No, it's the next one. Sorry, the recipient, thrombocytopenia. They get this polycythemia hyperviscosity syndrome, which is pretty rare, but can lead to limb and skin ischemia in utero and after birth. But what's interesting, it's like they were saying that a lot of the hematologic changes, not all the factors in the blood cross these tiny anastomoses. So it's kind of selective, like why do red blood cells do, but not other substances, which is kind of interesting. And then severe long-term neurodevelopmental impairment is seen in 9% of TAPS twins, with donors having increased risk for cognitive impairment and hearing problems. Hearing loss is quite high in that group. And this is just some babies. How am I doing? Okay, I have 9 minutes. Selective fetal growth restriction. It's growth restriction in one fetus of a monochorionic pair. It's due to discordant placental sharing. And then other contributing factors making this clinical course less predictable is the cord insertion and the size of the cord, as well as the number of the vascular anastomoses. The incidence is about it affects 10 to 15% of these twins, and you should always be thinking TTTS. So here's an example of a placenta. This baby has like the lion's share of this placenta, and this one's got a really filamentous cord insertion with a tiny little piece. Same thing here. And this is what this looks like. And these are babies like on day 12 of life. Another diagnosis that's controversial and not completely agreed upon. This is another Delphi consensus from 2018 that looked on at selective fetal growth restriction in dichorionic and monochorionic twins. The ACOG practice bulletin will say an EFW discordance greater than 20%. Or a 20 millimeter difference in the abdominal circumference among twins. And the newer consensus, so an AC less than the 10th, an EFW less than the 10th, a delta EFW more than 25% discordance, elevated Dopplers, and you need 3 of 4 of the criteria to meet diagnosis. Then there's this Gratakos classification of selective fetal growth restriction, where then you take this Doppler definitions and you lay that on a growth restricted baby. So there's type 1, 2, and 3. And so these are the Doppler waveforms for each one. So type 1, you still have flow. They can be normal or they can be elevated, but there's still persistent end diastolic flow. Type 2 is with absent or reversed flow. And then type 3 is this weird cyclic pattern where it's absent, reverse, and you can see the waveforms kind of changing here. And it's variable and scary, and I'll tell you why. So this is a 2020 paper showing the natural history of selective fetal growth restriction. It's very difficult to study this because, as you can see here, there's a lot of different cutoffs that people use in the existing literature to classify growth restriction here. And you can see there's like a wide range of incidents based on the different diagnoses. So what this study essentially showed is that early onset selective fetal growth restriction is more frequent than late onset, with variable incidence according to the gestational age cutoff used, 26 weeks, 28 weeks, 32 weeks. Early onset is associated with worse perinatal outcomes, mortality, infant mortality, and NICU admissions, and then superimposed TTTS. And types 2 and 3 of selective fetal growth restriction are more common in those that have early onset selective fetal growth restriction. Type 1, 2, 3, and 4, or sorry, type 1, 2, and 3. Again, for type 1, there's really a low risk of deterioration, about a 90% survival rate. It's often going to be expectant management in this group. Type 2, high risk of IUFD and a very preterm delivery with a very steady decline in the pregnancy, with about a 50% survival rate. And then type 3, although the survival rate is technically higher, they're about 10 to 20% risk of just sudden IUFD. It's the most unpredictable group with these large arterial anastomosis that can just confer a higher risk of survival exsanguination and that acute hypotension if one of the twin dies, because they have these big connections. So the blood pressure drop could be insane really fast. So management options, expectant monitoring with delivery if demise is appearing to be imminent. And then active fetal intervention with laser again, and selective reduction. So then this was a systematic review and meta-analysis from 2018 from Townsend et al. That sort of looked at the different treatment options for pregnancies complicated by selective fetal growth restriction. And so the study sort of showed that type 1, good outcomes with expectant management, type 2 and 3, laser and selective reduction. As you can see here, I kind of laid it all out for you. Associated with higher mortality, but lower morbidity compared to expectant management. And then previable fetal therapy may have a role in these severe cases to protect the surviving twin from demise or neurologic damage as a result. So I think there's more studies needed. We'll continue to hear more on this, I'm sure, with fetal therapy blowing up the way that it is. Okay, almost done. One more. TRAP. So this is cool. So this is the acardiac twin cardiac regression syndrome. It affects 2% of monochorionic pregnancies. Essentially, it results from a monochorionic placenta with these superficial arterial to arterial anastomoses that like really are not going through the placenta. I'm going to show you a picture in a second. So the anomalous TRAP twin, which is this guy over here, you notice there's only half of the body present, is perfused by deoxygenated blood from this pump twin who's totally normal and has normal circulation. This guy's not going to survive. So the best outcome is you have a healthy infant, this guy, the pump twin. 60% of these cases are diagnosed before 14 weeks and have spontaneous demise, with a 60% of pump twin demise or brain injury as a result. That's what makes this a bummer. Untreated pump mortality is about 50%. That's the normal baby, 50%. And so often these will be treated with cord occlusion or ablation to interrupt these vascular connections with really good survival for the pump twin. So this is what this looks like. You've got your little acardiac twin and a normal twin. So it's really good to think of the normal fetal circulation, right? Coming through the umbilical vein, through the ductus venosus into the IVC, across the heart, back down, out through the umbilical arteries to the placenta. I won't spend much time on that. So with TRAP circulation, this is what this looks like. You have the pump twin that's got normal, and then you have this anastomosis here. So this other twin is essentially being perfused by this deoxygenated blood from the pump twin, and it's going backwards through its umbilical arteries, which is supposed to be sending blood away from the fetus, but it's pulling blood towards it. And this deoxygenated blood, as a result, because it's coming in through the umbilical arteries, has preferentially goes to the lower half of the fetus, which then results in, abnormal development of the upper part, and the heart doesn't get perfused, and so it doesn't really develop. And so that's how that happens. And this is all here, but I'm for the sake of time. So this is what it looks like on growth path. So this is your normal, and then this is your TRAP twin here, and this is this connection. It's totally being fed. So the deoxygenated blood coming away from the normal pump baby then is going through the umbilical artery to the other baby. And so as you can see, there's various morphologies. The bigger the babies and the more developed they are, some can have rudimentary hearts. But the bigger they are, if they are to demise, that is a bigger deal to the pump twin, the existing twin. So there can be diagnosed on first trimester ultrasound. You get monochorionic twins with a crown rung length discrepancy. Some people think, oh, it's a vanishing twin, it's going away, but it might be an acardiac twin. You get a bradycardia or lack of cardiac motion in the smaller twin. It could have a rudimentary heart. And then on ultrasound in the second trimester, again, monochorionic gestation, one fetus with absent or rudimentary pump structure as a heart. And then Doppler, here it is here, showing retrograde flow to retrograde flow, so going towards the probe to this acardiac fetus, which is not normal. And then single twin demise, mono and dichorionic twins. I'm running out of time, so you can read about this here. I think the big thing to understand is that the co-twin death rate. So if one twin demises with a monochorionic twin pregnancy, you can see that the co-twin death rate, the preterm birth rate, significant cognitive neurodevelopmental complications are quite high, 20 to 30% in the surviving twins. You get this sudden loss of placental vascular resistance. The live twin essentially exsanguinates into the dead twin that just lost all that vascular resistance, and it causes acute hypotension in the surviving twin. And that hypoperfusion leads to ischemic lesions in multiple organs, not only the brain, but the kidneys and intestines. And these are all the effects that we could see. So the management of this to be counsel the risk of encephalomalacia and an ischemic injury in the surviving twin, as well as the risk of demise. You could consider head imaging, so an MRI for these babies. But they're not going to completely predict or exclude extent of fetal brain injury, as it takes like several weeks, potentially like several days to weeks to actually develop. And sometimes it's not even really noted until after they're born. If this occurs in a previable gestation in the second trimester, it's you cannot, it's wise to offer termination. And then demise, if one baby demises, it's already happened. The insult has happened. So you don't need to proceed with delivery, because now you're delivering a preterm baby that has all these other complications. Betamethasone course, and then you try to get them to 36 weeks. Okay, that is the end of my talk. Sorry, here are all the algorithms, which I know you guys really want to talk about. But this is just, I've left them on here and we can send these slides, but these are just management algorithms. This is SMFM from 2015 and then updated into 2020. ACOG SMFM, and they made you a little checklist, little box of what to do. Here's the NAFNet with is Fetal Network, the American Fetal Network Therapy Group. This is their 2015 consensus statement. And when they start using MCA Dopplers and whatnot. And then ISWOG seems to be the most aggressive in their monitoring. Looks like they start recommending UA Dopplers at 16 weeks in like normal monochorionic pregnancies. And then definitely by 20 weeks, adding MCA and umbilical Dopplers there. Most of them say growth every 4 weeks, sooner if you're worried. And then here's some fun facts on twins, because I had to end on a fun fact.
Haley, in the
Woo!
future, there's a lot to talk about here. So just so you know, everybody on this call, we're not doing any of this stuff. Like all those treatment guidelines, we maybe adhere to the ACOG, because we literally do not have ultrasound spots to do these things. So this is actually something that we probably should get. I've been here for almost 11 years. We've been doing the same kind of like piecing it together with a combination of bedside ultrasound plus formal ultrasounds for growth Q4. But this is definitely something that with our fetal treatment program and kind of advances in OB ultrasound and getting more organized, we should probably nail down, because right now it's very hit or miss, and a lot of times we'll order something and something totally else will be done and we're wondering why, and it's because there is conflicting guidelines. So I would propose, not this moment because we're already over hours, but putting together a group of people invested in twin imaging and then hammering out a consensus guideline and trying to adhere to it so that kind of everybody knows what we're doing in a shared mental model. Because right now it's, I would say the word for what we're doing right now is hodgepodge. That was a vocabulary word for my third grader. Hodgepodge is what we have, and it's probably fine for most twins that are not complicated, and it's not ideal for everybody else. So that's my suggestion. Yeah, Sean sent an email a couple weeks ago, so I think there is interest among multiple parties to revisit this. But
I like that suggestion, and I do have to say that I don't think we've had such an extensive review or people who are interested. We did start the therapy planning recently, so I think that it has come up more recently. So yeah, I've been asking for this exact thing that Haley presented, which is what protocols should we be using and what's the imaging we should be doing. So this is great. I think we should definitely institute this and have specific imaging, even in what exactly are we looking for in ultrasound and different twins, sort of listed out and make that into protocols, make that into, imaging protocols as well. So I'm glad we're doing this.
that was very extensive, Haley. Thank you so much. I know we are running out of time and there was no chat. So if anybody has one last minute question.
A lot. Sorry.
This is Swati. There's not a question, but the SMFM Pubs Committee is going to be at some point in the near future coming out with a monochronic twin complication consult review. So look out for that.
Cool. All right.
Thanks, Haley.
Nice work, Haley. Thank you.
So we've recorded this, and we might have it on our website if people have missed out on it. So just to let everyone know.
Oh boy. Okay.
Thanks, Haley. You'll be always, speaking and there always.
Good. Okay. Bye.
Bye.